Hello and welcome to the new Master Level webinar. This time we will talk about radiology in temporomandibular disorders. So we'll divide it in two parts because it's too much for one webinar. I don't want you to be overloaded with all this knowledge. And first thing we're going to start with is answering your question, when do we use imaging for TMD patients? Because it's not like the patient is coming to our office and we refer him straight away for the MRI. First, you have to have some initial diagnosis in your mind that you want to confirm with the imaging. So when you look at these stairs, we got a TMD management in here. It looks simple, but it's not always only a couple of steps. So what we always start with is a history. This is the most important thing if we talk about a TMD patient. This is much more important than an examination that we'll talk about in a second. So the first thing, the screening questionnaire, that is a modified COIS questionnaire. This is what I use, and if I have some doubts, I go a little bit deeper with this questionnaire. Another step is the exam chart. This is the examination where we check the range of motion, we check malampati, we check muscles, we check joints, and we make the final diagnosis. But as I said, if I have some doubts, if the patient is coming to my office and he's already saying that he has a TMD, he has some muscle pain, some joint pain, then I've got another questionnaire for him, which is the chronic pain questionnaire. And we have many difficult questions for them to ask, like post-traumatic stress disorders. We got many patients that have sex abuse in the past. Is that we have a patient that have some post-traumatic stress disorder resulting from death, resulting from some diseases. So people are chronically stressed, and sometimes they are coming to your office telling you that, and you are not listening to them. They say, "Doctor, every time I'm stressed, I've got bigger pain." It's like, oh, it doesn't matter. We have to do the bite equilibration. No. Listen to them. They are telling you the answer. You're always thinking about the teeth, but you have to listen to the history, when it started, how long it lasts. Is it permanent pain? Is it intermittent pain? Also, what is important is to give them the map to draw. Because when they finally get the pencil, they will draw. Where is the pain? What kind of pain is it? Is it a burning pain? Is it a burning pain? If it is burning pain, then it's really likely to be neuropathic pain. This is neuropathic pain that is not to be treated by the dentist, but the neurologist. So forget about the dental procedures for the patient with neuropathic pain. Although I know that some people say something different, but we'll not discuss it today. What we also give to our patient is a questionnaire that is referring to sleep apnea, the stop bank questionnaire. Because sometimes we give our patient the splint that we know that the patient feels worse. Why the patient feels worse? Sometimes because of the compression on the cervical vertebrae, sometimes because of the restricting the airways. Remember that when we are increasing VOD, it is like a scissors. So cervical vertebrae is compressed and the airway is restricted even more. So diagnose it first. If there is no restriction in here or in here, if you don't want to make your patient worse. But if we know all of that, if we know that the patient has some acute problem in the joint, or we are in doubts, whether it's a muscle problem or a joint problem, but we know for sure we have to look inside. Then we are going one step further from the examination to the imaging to confirm our diagnosis. It's not like we are looking at the panoramic X-ray first, then we see some bone degeneration, and we say, "Oh my God, I will not make a veneers for you because I see there is something." You don't really know what it is. You didn't confirm it with the CBCT. You didn't confirm it with the MRI, but you know there is something. Maybe this guy is just off the disc for 30 years. There is a chronic degeneration. You didn't even ask him whether he feels fine or not. You just made a definitive statement. You are sick, and I see it on a panoramic X-ray. Don't do that. Don't do that. First the questionnaire, then the examination, and then we got the imaging. So, talking about imaging, we got some couple of different possibilities. We can have the MRI, we can have the CBCT. I hope you see the difference, because on a CBCT we mostly see the hard tissues. In the MRI we see also the soft tissues, and this is the biggest value because we can see the disc, we can see a fusion in here. In here we cannot do that. The ultrasonography, honestly, I cannot imagine using it, because then my brain is upside down. Because when you use that, it's not like our typical dental thinking that this is the fossa and this is the anterior part of the head, there is a posterior part of the head. No, 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 nothing like this. When you use ultrasounds, the skin is in here, there, then you go to the muscles, then you go deeper and deeper and deeper. This is a completely different thing. So we'll talk a little bit about that today, but not too much. Don't be too much stressed about that. And we've got also plain 2D pictures that sometimes can make you really confused, because we've got some overlapping structures, and we don't really know what's the real position of the condyle. We don't really know if there is a cortical bone, not to mention the disc. So let's start talking about imaging. If we start with imaging, we have to know a little bit of the history, because it's not like we started it 10 years ago. This is a picture from London in 1920. So we are doing imaging for 100 years already. And there are still controversies about the radiation, about the harmful effect of radiation. And the internet is full of very nice comparisons. Like, if you eat 2 bananas, it's like one small X-ray. If you spend 1 day in Grand Canyon, it's like 6 X-rays. If you fly to Los Angeles from Europe, oh my God, how many X-rays is it? Do you think the stewardess or the pilot in a plane, they have a bigger risk of a cancer? I don't know about it. I don't really know if they are at higher risk. Never heard about it. We think about the food as a big dose of radiation, and in fact, if you do 1 X-ray, it's like 12 Brazilian nuts. Should we stop eating Brazilian nuts? Or maybe we should move to another country? Because if you live in Iran, then your daily dose of radiation is like if you get tomography every day. So do we really have to be worried so much about radiation in dentistry? If we speak about digital radiology, it is not that big deal as it was in the past. If we speak about CBCT, it's not that big deal as it was with typical tomography. And so, you know, we are going further and further with the radiology, so we are reducing the dose. So I do not think this is necessary to be so much afraid of taking pictures, but let's be reasonable. We do not do the big CBCT for our patient and a couple of them just to compare some structures, just to make a nice presentation for Facebook. Let's not treat our patient as an experiment. This is my message to you. So if you really need it, don't think about the harmful effect of radiology, but only if you really need it. So keep your questionnaire and keep your examination in your mind just to decide if you really need imaging. And talking about imaging, what is the most common thing when we talk about the radiology in dental offices is the panoramic X-ray, right? So we could spend a lot of time to discuss all these points, to discuss every single detail, but we will not talk about it so much because today's webinar is radiology in TMD. So we will mostly focus in this area, in the area of temporomandibular joint. So let's look at it. Let's look at it, what we can see on the panoramic X-ray. On panoramic X-ray, we can compare two condyles. We can compare if the fossa is higher or lower. We can check if there are no fractures, if there are no tumors. When you look at this CBCT, if you look at this panoramic X-ray, and you don't know too much about TMD, you could look at it and you could resign from the treatment because you say, oh my God, as I mentioned at the beginning, there is something wrong. But what does it mean, something wrong? Does it bother your patient? Does he feel okay or not? What's your problem? What's his problem? Why do you think this is problem at all? Maybe this is just a chronic degeneration that lasted over the last 30 years and the patient is done. Adaptation is done. So questionnaire and examination, not only panoramic X-ray. In here the same. You could see that there is something wrong in the condyles. And actually in here I see bigger problem, and maybe the left one, I see that the surface is not even. So if this patient is symptomatic, I would definitely refer the CBCT for both condyles. But if the patient is fine, and I do not see anything terribly suspicious, like a tumor or something, I will leave him alone. Let's leave your patient alone if he's fine. We are not looking for the problems that do not exist. The same thing in here. This is also adaptation. You see that this patient doesn't even need posterior T because he already adapted. His occlusion is already adapted. He's chewing on the bone. How do you like it? I look at the condyles. The condyles are flat. So for me, it looks like a rheumatoid arthritis. But you know, this is for sure combined with the lack of the support at the back. So probably we got some couple of issues in here that created that image of the condyle. What do we got now? So this is probably the eagle syndrome. When you see that long styloid process. But what does it mean there is eagle syndrome? Eagle syndrome you got when you got symptoms. But when your styloid process is longer than 4 centimeters, mostly 4 centimeters, because then, according to studies, it becomes the patient becomes symptomatic. So in here we also see very, very nice eagle styloid process, very long and nice styloid process. In here as well, what you can see. All right, so you can see that on the panoramic X-ray. Sometimes you got some pseudo joints in here. It means that there is a calcification of the stylohyoid ligament. There are a couple of theories why it happens. Some people say this is because of sleep apnea and a big tension on this ligament. So when you look at the CBCT, you can also see this. This is the styloid process, and we see that this is already 4 centimeters. So it may be symptomatic. Funny thing is, this is the same patient that I found. This is my office. Styloid process, very long, and a bifid condyle. The theory about a bifid condyle is very complex. Some people say this is a developmental problem. Some people say this is because of trauma. But the thing is that sometimes you will see it with your patient just accidentally. This is very often asymptomatic, so this is not a real problem for your patient. Bifid condyle is not that big problem for your patient. What we can also see on the panoramic X-ray, and sometimes you can see very nice thing on the Facebook. So take a look at this. This is the big fracture, probably because of some dentists tried to extract the third molar, and then we got a fracture on the angle of the mandible. What do we have here? Here is also the fracture, and you can see it with the black arrows. There is a line of the fracture near to the condyle. But as this study says, actually, we can diagnose many nice things on the panoramic X-ray, like fractures, like tumors. But to diagnose temporomandibular joints, CBCT is much better, and we'll discuss on it later on. Before we go into the CBCT, I have to tell you that one of the most often reason why patients come to my office, even referred by other dentists, is because of clicking. So we know that we do not treat clicking unless it's symptomatic, but very often patient is coming to my office because he has a clicking which actually has nothing to do with the disc. So I'm telling, okay, can you open, close, there is no clicking. So I'm asking, so where is the clicking? And then the patient is opening the mouth so much that they can put a fist in the mouth. So this is nothing to do with the disc. This is the subluxation of the condyle. So take a look at the right, on the left condyle. What's happening under the skin? So you see that this condyle is going to the excessive translation. The left one is fine. Sorry, the right one is fine. The left one is wrong. This is subluxation of this condyle. So remember that there is a difference between the tendons and ligament. Tendon connects the bone with the muscle, and it is elastic. Ligament connects the bone with the bone, and it's mostly made of collagen fibers that are not elastic. So once you stretch it, this is like a leather belt. It will never go back to the prior length. So you have to give your patient an indication not to overload it even more, not to open into the excessive translation. So we can diagnose it with some plain 2D pictures. And actually, if you use them, I think this is the only indication for those pictures, to check the hypermobility, because we do not see much more than that. So in here, there is a hypermobility because you see that the eminence was here and the condyle is in here. So it goes too much forward. Of course, when we got a big pathology, you will see a little bit more. Like in here, you see the osteophyte. You see that the bone morphology is a little bit changed, but it must be a big deviation from normality if you want to diagnose something in here. And this picture is a picture of the hypermobile joint, and it was only 2D. In here, you got a 3D picture. So let's take a look what you got. This is the fossa in here, and this is the condyle. So the condyle should stop in this position. So it goes too much forward. So this is subluxation or luxation if the patient cannot come back. And even better is on the MRI. This is the open mouth. This is the closed mouth picture. So this is the fossa in here, and there is a condyle. So condyle should stop in here at the apex of the eminence. So it goes too much forward. So we will talk about many CBCTs and MRIs today, and the biggest confusion is actually the colors. Because what you see as white in here is the hard tissue. So what is hard in here is black. Hard in here is white, hard in here is black. So the cortical bone in here will be black, like what is seen here, and the cortical bone on a CBCT will be white. And we will talk about black and white pictures, and especially if we talk about black and white pictures, sometimes some small details make a big difference. So when you look at this, most of you probably already see Adolf Hitler, and when you look at this, most of you probably see the priest. So you see there is a very small difference in here, but it makes a big difference when you think what is the final outcome? What is the final outcome? So when you give somebody the hammer, you will see the nails everywhere. This is why I want you to see many CBCTs and many MRIs today, because the more you see it, the faster you're going to make a diagnosis after all. The faster you make a diagnosis. And it will not be just a black and white, don't know nothing about that. When you finally know how the disc looks like, you will know straight away if this is reposition or not, if this is reduction or not. So coming back to our CBCTs, when you look at this skull and you look from this perspective, this is the sagittal perspective. When we go a little bit closer, we see the condyle, you see the eminence. And when you look deeper in it, so this is double convex structure because the eminence is convex and the condyle is convex. So this is why the nature gave us a disc to create a double joints, the upper one and the lower one. But let's not talk about a disc right now. Let's talk about the contours that we see in here. The contours that we see in here is a cortical bone, and you can clearly see it because it's white, and it is not interrupted. There are no erosions in here. There are no osteophytes in here. There are no cysts in here. So this is the sagittal view. Now we got a coronal one. Coronal one means that you look from the front or from the back, but you slice the head this way. So you see the condyle that looks like this with the cortical bone that is white. We see the joint space that you can also measure. So how we do it, I will show you an example of the curve stream, how we calibrate what we look at. Because first of all, you have to localize the condyle, then we have to make the arrows on the particular projection. So if we go a little bit higher, then we see where the condyle is. You have to localize where is a medial pole and where is a lateral pole, because you have to cross these 2 points to make the reference line. And we do that. And what you see now in the right lower corner is that we already have the coronal projection. And you see beautiful condyle in here. You see the cortical bone of the condyle. You see the joint space that you can measure. So you can take a ruler and you can measure the space if this is enough for the disc. Maybe it's too narrow, maybe it's too wide, maybe there's destruction, maybe there's compression. It looks fine. For me, it looks fine. Then you can also calibrate it in the midline of the condyle. So in the sagittal projection, you can also see it very nicely. To take a look, what we see now is, this is the ear hole, this is the fossa and the eminence, and this is the condyle. You can also clearly see the joint space. This is not symmetrical, but we do not symmetry in here because the nature is not about a symmetry. Physiology is not about a symmetry. So this is the middle point for the middle part of the disc, and this is the disc for the space for the distal part of the disc. Because if we speak about the joint space, you have to know what is it for. The joint space is for the disc and for the soft tissues. So this is called the condylar vertical dimension, and when the disc jumps out, it collapses. So the condylar vertical dimension is decreased, and we can also call it the joint space, just the joint space. So let's take a look how the healthy joint works, and it looks best on this video. We see that the condyle is going into the excessive translation. This is hypermobile condyle because it doesn't stop at the apex of the eminence. But what we also see is that the condyle is going all the time with the disc on the top, with the disc on it. There is no subluxation of the disc, and there is no actually also reduction of the disc because the condyle is all the time in a place. And this is not the beautiful symmetry in here, what you saw, because as I mentioned, we will not see the pure circles in the anatomy of our patients. In here you see the irregular shape. In here you see the irregular shape, but also in here you see the irregular shape. You will not place the ball inside. because our condyle doesn't look like a ball. So we, the dentists, we really love symmetry. So we are trying to figure out what's the ideal position of the condyle into the fossa according to the measurements. We love maths. We love numbers. We love 0-point dentistry. So we are trying to make the ideal position of the condyle to make sure that we do our best. I'm telling you that the symmetry is not that important unless the condyle is not far away from the central position. It's not far away from the central position. So some of you probably already saw my webinar about centric relations. So we were talking for 1.5 hours about the couple of positions of the condyle in the joint, and you know that most of them can work really well. But what probably will not work well is when the condyle is distalized. It's much better if it is too much forward than too much distally, because then the ligament is stretched, then there is a compression on the synovium. So it's better too much forward than too much backward, as we could say. So the symmetry is not that important if the patient is asymptomatic. Also, you will not see beautiful condyles for every single patient. In here, you can see that there is a very, very little condyle, and you could think that maybe this is the child. But if it is a child, it's fine, because the eminence normally is not fully developed by the age of 23, 22. But in here, this is definitely not a kid. The eminence is fine, the cortical bone is fine, but this condyle is just very little. And the smaller the condyle, the bigger chance that there is going to be some disc internal derangement, because the distribution of forces on the small condyle is much worse than on a big condyle, right? This is why this is a risk factor for the disc displacement in the future, small condyle. And on the other hand, this is not a patient of mine, this is the huge condyle. But this patient is not a healthy person. It's not just his nature. It's not his nature, because this is the symptom of some general disease. This is a symptom of the general disease. In here, what we have is arthritis in here with the eye of the bird and with the beak of the bird. So this is why Mariano Rocabato was talking about the zoo, because we got different animals in here. So take a look at this condyle. That looks terrible. So why I'm saying this now? Because in some books you will read that especially in this book, you will read that our studies involving hundreds of recordings always show the uppermost position to be a point. There is no flat area at that apex, so only downward movement from the apex is possible. Oh, really? I don't want to talk about it too much, because we already talked about it on the CR centric relation webinar, but just in shortcut, we assume that our fossa looks like this. So when you put a pressure on it down upward, the condyle always will make this road upward. Upward. And it will stop in here with a single magic point. So you already also saw this study, and you know that in this study they took 596 asymptomatic patients and they placed them into the centric relation, and it turned out that 99.5%, this is a big number, are not in centric relation, because they had some premature contacts at the back after placing them into the centric relation. So is it really physiology, or is this just some reference point that we are directing our patient into when we increase vertical occlusal dimension? So this is not time to discuss about that. If you want, you can go back to the centric relation webinar. But why I'm talking about this now, take a look at the results at this conclusion. About 11% of the people had only the parallel movement on the top of the fossa. So the fossa on the top was flat. There was no magic point of centric relation. So we will have different condyle. John Coyce used to say, my condyle is not a ball, my condyle is a potato, and my potato is different than your potato. So we do not have balls into our joints, we have balls in the articulators. This is why it's not so good to use only the articulator. So you see the variabilities of the condyle and statistics of those variabilities. You see that you can have different condyles and different fossa. So one of them will be flat, one of them will be very steep. So when I look at this, and that would be my patient before spleen therapy, I would rather expect him to go backward and upwards. So probably he would develop the anterior open bite after all, after stabilizing his condyle. When I look at this condyle, I think that the bite will not change significantly after spleen therapy because it is already into the uppermost position. And if we talk about it, and we will go back into this in a second, this is too much upward, too much. This is too high because there is actually no space for the disc. So if you have this type of patient that you can see on the right, it will be easy for you probably to find a stable, reproducible position while you do the dosing manipulation. But on the left, if your fossa is flat, then that will not be that easy to find that magic point. And do we really need that magic point? Or maybe we got a comfort zone and that's fine? Think about it. Think about it. What the study says, what the literature says, and what your patient tells you. So, coming back to our skull and to our condyle, this is what we see on the CBCT if we talk about a sagittal projection. Now, is it a good position or bad position? Is there a space for the disc? You're happy because you see the symmetry, right? In here, everywhere is symmetrical. It looks like very stable joint. When you look at these contours, you also see very nice position, right? There's a pure symmetry. But think about it, where is the space for the disc in here? And is the disc flat or the disc is biconcave? Look at this. There is a very thin temporal bone in here, very thin temporal bone. So it needs a shock absorber, and this shock absorber is a distal part of the disc that is pretty thick. Because when you look at it, this is 3 millimeters at the back, 1 millimeter in the intermediate zone, and 2 millimeters in the front. And this is how it looks on the cadaver. So there is a thick portion at the back, middle portion thinner, and a thick portion in the front. And this is how it looks like from the transversal projection. So where is the space for the disc in here? Of course, there is no space for the disc. So if the disc is in there, it is either compressed or it will be squeezed out. So once it's squeezed out, the space is even narrower, is even more narrow than if you look at those two joints. Which one do you think could be symptomatic? You don't know the history, you don't know the examination, but you just see those two pictures. Which one do you think has a worse prognosis? That one or this one? Of course, this one. In here, maybe this is too big distraction. Maybe the condyle is too far from the fossa. But honestly, I do not think so. But in here, there is too big compression. So take a look at this video. What do we see in here? If we change it from the medial pole to the lateral pole, we see that the space maintains very narrow. And we can also measure it. 1.3 millimeter. You already know that the disc is 3 millimeters, not 1.3. So this is too narrow. There is no space for the disc. And now we got a coronal projection. We can do the same. So you see the space and we can measure it. We take a ruler and we check. How much of the disc can fit in here? No disc can fit in here. No disc can fit in here because this is just too narrow. So having those two joints, you can already have some initial diagnosis in your mind that there is a problem in here. But our joints work together. So when one is going up, very often another one goes down. And when it may happen, this is kind of controversial gnathological conception, and I'll tell you that it may work when let's say you deliver the crown for the patient, it is 2 millimeters higher, and you have no more time to adjust it and bite because another patient is waiting in the waiting room. So you tell your patient, okay, go back home, you come back tomorrow and we'll adjust it. 2 millimeters, maybe it's going to be too high. So our body is not designed to be in centric relation, but we, the people, evolutionary, we developed to eat properly and to survive. So therefore we have to have a MIP, maximal intercuspation. So if we have a space in here, your patient will definitely move the masseters to connect those teeth to eat properly. So when those masseters will contract, that condyle will also go higher. Then either it will compress the disc or it will squeeze the disc out. So one more time, I will go back, take a look. We start from here, we bite strongly, and then our occlusion is changing, and then our condylar vertical dimension is changing, and then we can see something that looks like this. So one condyle is going down, another one is going up, and another one is going up. So when you look at our diagnostic chart and we take the imaging, you see that there is a narrowing of the joint space. So this is what we choose to, and this is where we sign in here. Narrowing of the joint space. We will discuss every single part of it today, so you'll know exactly how to make the diagnosis. And coming back to our disc, the disc may be either compressed or maybe squeezed out forward, but sometimes the disc that goes forward pushes the condyle backward. Like in here, what you see, and this is what you can see on the CBCT. So, you know, I told you the symmetry is not that important, but if the condyle is far away from the central position and your patient is using your muscles strongly, because that may be asymptomatic easily, but if your patient has some other problems and the compensation and adaptation doesn't work well, this may become symptomatic. When it may happen, especially if you have something that's called constricted chewing pattern. So when your patient is, especially after orthodontic treatment and closing the spaces between the teeth, we create the premature contact on the frontal teeth. Then your patient is trying to connect molars, and to connect molars, he must slide backward on the palatal surface of upper incisors. Very often you can see the destruction on the palatal surface of the upper incisors, but it doesn't indicate the active problem. It may indicate the problem that was active in the past and the patient has already adapted. So this is how it may look like. The patient is closing. He's closing first on the palatal surface of the incisors. Then he wants to connect the molars, posterior teeth. So he slides backward to finally get the contact on posteriors. So while the incisor is sliding backward, the same, so does the condyle. And it may sometimes look not only like a distalized jaw, but the slide laterally. Take a look. This is a patient after spleen therapy, and the bite is pretty stable, but after getting to the, once I ask her to go to the MIP, you see the slide, the centric slide. Oh yes, centric slide to the right. So there is no distalization of the jaw. There is a lateralization of the jaw. The same in here. Take a look. Take a look. Patient is closing. And what happens to the jaw? Sliding, shifting to the right. Shifting to the right. So your jaw can be pushed backward, but sometimes you will have a rotation of your jaw. So one condyle will be distalized and another one will be a little bit more forward and for sure will be more laterally. Like you see on this picture. One condyle is pushed backward. So this one is pushed backward. This one is moved forward. Then take a look at this video. We look at this condyle and we think that especially in sagittal projection, it doesn't look bad, right? But the patient is symptomatic. The patient has a pain. And when we go to the coronal projection, we see that really, actually, there is something wrong. So the position of the condyle is too much lateral. So it's too close to the temporal bone. The condyle is shifted laterally. Take a look at the medial distance. So when you know that the sagittal projection is pretty nice, but the coronal one looks, as you could see, then you think straight away about the rotation of the mandible. You see this? This is another joint of this patient. This is another joint of this patient, so we see that another one is distalized. So you think straight away, all right, this one, the lateral pole, is too much laterally, and this one looks this way, so we know that the mandible is rotated, and this condyle is distalized, and in here the lateral pole sticks too much outside, right? So this is how it looks like. This is how it looks like, and you see it on the pictures. That condyle, why you see it too close to the temporal bone? Because this lateral pole is going outside. You remember that the jaw, when it's opening, the condyles are going, the condyles are spreading, right? They are going much further from each other. This way. Every time you go into the protrusion and every time you open, the condyles are going outside. So they are going closer to the temporal bone. On the other hand, that condyle is distalized, that you can clearly see on the CBCT. So how do we mark it on our exam chart? Big deviation from the central position. This is what we choose as a partial diagnose. This is what we see on the CBCT. So it cannot be full diagnosis because we still need the examination and we still need the history. So when you look at this, what do you expect after spleen therapy, and what would you say about this position? You got 10 seconds to think yourself. When you look at this condyle, what would you think? Probably distalized, right? So after spleen therapy, maybe this patient would go a little bit forward. So maybe you could get the initial context on the frontal teeth. When you look at this condyle, you see that there's a big distraction. This is more than he needs. This is more than the patient needs for the disc, right? So maybe once you put the COIS, the programmer, or the NTI splint, or just the splint, or you make the Dawson manipulation, what's going to happen? The condyle will go up to fill this space that is probably too big. So what would you expect is the premature contact at the back after all? But there is not the best position. There is not the best position. We already talked about many different positions that work for years. Otherwise, nobody would have used them for so long if they couldn't be successful. But this probably is the worst one, because then the ligament is tensed. And you know that the tensed ligament will stretch, so then the condyle can go even further backward. This position probably is not the best one, because there is not enough space for the disc. So according to the latest studies and to the latest knowledge, that would be the best position, that is most upward and forward, right? This is our famous centric relation. But it's not so easy to get the centric relation when your condyle looks like this. When your condyle looks like this, take a look at the left. This is an 85-year-old woman that has osteomyelitis when she was 10-year-old. 10-year-old. So this is 75 years after the problem appeared. So and when you look at this, condyle, you see one condyle, another one, and another one. Very, very interesting image. Now, what do we have in here? This is the condyle hypoplasia, and this is after the radiotherapy. This is after radiation therapy, and also notice the length of the roots in here. They are very, very short. Now, take a look at this, and you got 10 seconds to tell me what you see. This is right condyle hyperplasia. You see the ramus of the mandible? It is huge. It is huge. The same condylar hyperplasia you see in here. There's a big difference. The right one and the left one. You can clearly see it on a CBCT, but you could also notice that on the panoramic X-ray. And when you look at these teeth, you could think that the joint is probably very, very destructed, right? But it's not. But it's not. This patient has a cerebral palsy, so he's grinding significantly all the time. But when you look at the condyle, it looks fine. What doesn't look fine is his scoliosis and the rotation of the second cervical vertebrae. So when we look at the skull, you look at the cervical vertebrae, and we can easily see the spaces between them. But you can also look inside your spinal cord, and you could notice if there is some rotation or not. By the way, this skull is made of CBCT. So this is exactly the skull of our patient, of our beautiful patient, right? So you can easily see all the cervical vertebrae. You can easily see the styloid process, and you can also see the hyoid bone with the horns that we will talk about after a while. Then the condyle position is fine, and the condyle morphology is fine, but what is not fine is clearly visible in here. And take a look at the teeth. It looks like a samurai sword, you know, somebody cut it off. This is amazing how it looks like. Also, this is from the intraoral camera. Okay, what we've already spoken about was the panoramic morphology, panoramic disorders, what you can see on the panoramic X-ray, and what are the limitations of the panoramic X-ray, and every single 2D picture with some overlapping structures that may make you very, very confused. What we already talked about is the space, the joint space in the CBCT, we know how much do we need for our disc. So we already know what is too wide space and what is too narrow space. What we already talked about is the position of the condyle. When we talk about eccentric relation, when we talk about the big deviation from the central position, because we do not need a symmetry. Asymmetry is fine as long as it stays asymptomatic. But when the condyle is too far away from the central position, when there is a big deviation from the central position, it may not be okay for the patient that uses his muscles really well. So what else we have for the second part of the webinar is this. Is the most important thing if we talk about the TMD, if we talk about internal derangement, internal intracapsular disorders. This is the erosion of the cortical bone. Because if we have active erosion, our treatment is not finished. You cannot make orthodontic treatment, you cannot make prosthetic treatment if you have active erosion on the top of your condyle, because you will end up with a new open bite after every 6 months. You have to know if this is acute or this is chronic, if this is osteoarthritis or this is osteoarthrosis. This is what we have to learn in the second part. Another thing, what we must learn is the joint, the disc position, and we will read many MRIs, so you will know exactly where is the disc, whether it's reducing or not, what are the effusions, how do we recognize the cortical bone on the MRIs. This is very important to know how to read the MRIs, but it is also important to know how do we read cephalometric picture. What may be the consequences of increasing vertical occlusal dimension through the airwaves? What may be the consequences of increasing vertical occlusal dimension to the cervical vertebrae? How do we recognize the airways on the cephalometric picture, and how do we recognize it on the CBCT? This is very important to know if the patient is fine, if he hasn't got any sleep apnea, if we can increase VOD for him or not. Maybe he's gonna need a physiotherapist, maybe he's gonna need the ENT doctor. We will talk about many pathologies, so you will find out where it comes from when the patient is coming to your office saying, "Doctor, I got an open bite in here that I haven't got before. It happens now. It happens last 6 months. So how on earth? How can she bite like this after all? With such a big gap between the teeth?" But what is also important is to know the difference between the MRI and the ultrasound. What is better? What is more useful? What is easier to be done? But to use your MRI easily, you have to know the anatomy. You have to know function to start learning about a dysfunction. So we'll talk about the ideal position of the disc, ideal movement of the condyle. We will talk about anatomy and the physiology of the muscles on the MRI to know what is pathology and what is physiology. You will see some videos of my patients that I will tell you exactly what do we see on the MRI, what do we see on the CBCT, and most of all, you will have your time to make your diagnosis and to summarize your knowledge. Because if you can decide what you see on the picture after 10 seconds, then I'll be glad that I helped you to move forward. So let's call it even for now, and let's start the new webinar in a second. Thank you very much.